We are very pleased and honored to present the Outstanding Achievement Award for 2022 to Marie-Josée. And what it says is, and I broke my glasses, so I got to read this without glasses. Hopefully I do this. In appreciation of a distinguished career dedicated to the treatment of so many of us affected by prostate cancer and its side effects. Again, thank you very much for all the wonderful work you've done with us. We really appreciate that.
I guess before we get officially started, I know Mylan had something that he wanted to say as well. Mylan is our secretary, our steering committee secretary, and he just wanted to say a couple words before we get started. Come on up, Mylan, and I'd go around because there's a lot of cables here. Just a few secs. You're not sure? Maybe, oh, okay.
Yeah. Well, what I wanted to say is the Masons, the Harmony Lodge, had asked me to pipe at the Remembrance Day ceremony, which I agreed to do on one condition, that instead of paying me a fee, they would donate the money to the prostate cancer support group. Now they have done that. There was, unfortunately, the Secretary David Apps was going to come here today and do a little presentation. He lives nearby, so he must have been caught in traffic or whatever. But he sent me a picture of the check and the letter, so we'll be getting that. So I thought it was also a good opportunity. I talked to the Masons there because they're all men of our age and some younger, and I said, this is a prime group that could potentially have a number of members that have COVID, not COVID, prostate cancer, COVID, yeah, and COVID too, yeah. And so I'm going to be writing an article for their publication, advising them to go and get tested. So, you know, I think it's a good audience that we haven't reached yet, and hopefully we save at least a few people. And so.
Still trying to figure stuff out, or you're good? Okay, so you guys have everyone's okay on Zoom there? Thank you so much for coming tonight on Zoom. I'm sorry I'd forgotten you guys. I was just so happy to see people in person tonight that it's like, wow, who cares about Zoom anymore, you know? But we'll work on that. So, so Marie-Josée Lord is going to give about a 45-minute presentation, and I'm sure you guys have a lot of questions. I know if you guys have already spoken to in the audience have some questions. Please, I don't know how much time you have for questions, but 11 o'clock is good for you guys, you know, because she has a hockey game at 11 probably, right? You know, playing, not tonight. Okay, all right then. So, so Bob, I'm working on those tickets for you, by the way. Okay, so hopefully we'll get those. So anyways, without further ado, obviously, looking forward to the presentation, Marie-Josée, and good luck with everything.
Thank you very much. I really want to thank you for the award. That's very nice. I remember the first meeting that this group had, and I was there with Dr. Kuzmarov, and I was standing in the back, and I can't believe all the work that's been done since. I mean, it's wonderful. I think over the years, I forget, when did it actually start? When was the first day? 95, 96, that's what I thought. I just didn't want to say it because it's a long time ago. But yeah, so I really feel that the group has done so much work. Congratulations, because it's something very needed. I find that, you know, it's been 30 some more years that I work in pelvic health and have seen a lot of men with prostate cancer. So I think it's something that's not talked about enough still today after so many years, and what can be done about it. So let's begin. And I'm gonna just, when I'll reach and I'll come back in front of the cameras just to be able to move the slides. So I want to talk about what is urinary incontinence. So there's many definitions to urinary incontinence, and it is the involuntary loss of urine. Does it? Oh. Yes. So people on Zoom had an advantage this time. Oh, why is it doing that now? I'm not seeing it like that on my computer. Okay. Oh boy. So now I have to get off of the share again. But it wasn't doing that before. Okay. If I go into, I'll go into use presenter view, or let's try this one. Okay, so I'll get off of this. Why wasn't it was doing it okay before? It shouldn't. So should we leave it like this? Okay, let's leave it like that. I can't make it any bigger, I don't think. Can I make it bigger? No. So we'll just try to, that's not the, I could make it bigger than that, but it's just not. Okay, well, let's keep it like that. And I do, but that's what happened when we put it on. Try it again. Okay. So if we do that, I'm not seeing it the same way as, usually it's the opposite. The computer sees it and the projector doesn't. See, I'm not seeing it like that at all on my computer. Yeah. So I think I'll have to go back to the other one. I mean, it's not, it's because people here are not going to be able to see the. Maybe one day we'll get going. Okay, how's that? I can't do slideshow. That's what was showing before. So is that okay? Okay, so let's keep it like that. And people on Zoom can see it? Okay, good. All right, so then I was over here. So the incontinence is it's an involuntary loss of urine, and it can be a few drops to a larger amount. So the amount of urine loss does not determine if you have incontinence or not. As long as you lose urine involuntarily when you don't want to, then that's considered incontinence, okay? The prevalence is pretty high. It is more common in women than men. If we talk about just population in general, there are probably 1 in 3 women that has incontinence. And we don't have high numbers like that for men when they don't have a prostate treatment, prostate cancer treatment. So we do usually see the incontinence with men that had a prostatectomy or had some radiotherapy. Okay. So usually the prevalence, I mean, it's depending, when you see large amount of like a percentage that goes from 5 to 35, it's usually because they can't agree as to when some studies are showing something when it's really large. But this is what's reported in the literature, is usually about what they call partial incontinence is somebody that will lose here and there. It could be a lot, but it's not constant. It's not like a drip, drip, drip. It will happen, you know, when you cough, sneeze, and then it will happen by getting up from the chair. It will happen in different instances, but not constantly all the time. So the people that have it constant, it's about 1 in 5% after prostatectomy. But the people that have the partial incontinence, and again, that could be from a few drops a day to filling 3, 4, 5, 6 pads a day. And that's the range is about 5 to 35%. So the risks are always because of the biggest risk is with surgery. And I'll explain why. I think some people that have heard me before will know why, but I think going over it is sometimes a good idea. So I'll use you should be able to see the pointer on here too. So when we look at the anatomy, we have the bladder, and the prostate sits right under the bladder, okay? So when we look at it over here, that's in big, we have the bladder and then the prostate right under, and we have, when it's filling up, the sphincters at the base of the bladder are holding the urine in. But on top of that, we have the prostate that helps to hold a little bit of the urine. It helps to put a pressure on the urethra, which is the tube where the urine comes out. So when the bladder is filling up, usually it relaxes and it starts to fill up. When it's time to go to the bathroom, it will contract. So that's the urge that we get. It's like a spasm of the bladder and it contracts. So that's how we empty the bladder, is because the muscle of the bladder squeezes, and then that will cause the urine to evacuate. So there are 2 types of incontinence, and this is important because we put all the incontinence in one basket and we say, oh, I have leakage. But when you have leakage, it could be very different from one type of incontinence to the other. And I see that all the time, that people are saying, well, I'm leaking, and they're doing the wrong thing because the leakage is because of one thing, and they're actually doing either exercises or doing something to help the other type of incontinence. So there are 2 types. The stress incontinence, and that's not because you're stressed, it's really because of an effort. So it's a push into the abdomen on the bladder, and that causes some leakage. So for example, it would be if you cough, you sneeze, you pick up something, so that pushes down into the bladder, and that will cause some leakage. So that's called stress incontinence. Then the other one is called urge incontinence. But the urge incontinence after a prostatectomy is a little different than the regular urge incontinence if people didn't have a surgery. But what happens is that the bladder goes into these spasms without telling you that it's going to go into a spasm. So you could be sitting there and all of a sudden there's a few leaks. And that's because the bladder is nervous. And the nervousness is usually because there's been a removal of the prostate and there's less pressure on the urethra. So when we look at things that increase the abdominal pressure, so our stress incontinence, it's all about pressures going down. So from the diaphragm, if I'm coughing, I won't put the microphone too close, like this, then it pushes down onto the bladder. And if the muscles or the sphincters are not quite adequate, or the timing is not good, then there's going to be leakage. Okay, so usually it's things like coughing, sneezing, lifting something. And then the urge incontinence in people that have not had a prostate surgery or radiation, it will be that there's an urge to go. So let's think we're not going to think about surgery and you probably will recognize your wife because it's more common in women after menopause. Like they get home to put the key in the door and it's like, oh my gosh, I'm not going to make it. I'm not going to make it. It's just too urgent, or like, I've got to go. Well, this is urgency. And if there's leakage, then it's called urge incontinence. But after a prostatectomy, as I will explain to you, it's that kind of stuff, but a little different because sometimes you don't even get the urge. You just get the bladder to contract and then it leaks. It doesn't warn you. Where usually urgency, it warns us a little bit. Maybe not a long time, but it warns us. So what is the incontinence after? So we said we had, I'm going to take the bigger one because it's going to be easier. So you see part of the bladder at the top, and here's the prostate, and here is the sphincter that we can contract, okay? So when they do a prostatectomy, this is the way it is normally before the surgery, and after the surgery, they remove all of the prostate. They do damage the internal sphincter, which is at the top right here, and then they reconnect the top down with the bottom, and this is what happens. So there's a loss of a sphincter, and a sphincter, it's the main one that is lost. So the second one has to do the job for the first one, but it's not used to it because nobody sent a memo. So it's like, I don't know what to do here. Like, I was just a helper before, and now you're asking me to take the job over, and I don't know what to do. So this is why we have to train that muscle, and we have to not just train it to know like that it's strong, but we have to tell it what to do and when to do it. So that's the part that a lot of people forget. They do exercises. So it's like the person doing weights and preparing the muscles. But when it's time to go lift a box, they're like, well, I don't know how to lift this box. I've never done it before. Nobody showed me. So this is what has to be done, is you have to train that sphincter, the second one, to learn the job of the first one that was removed. So when there's a pressure coming on the bladder, like I explained, like coughing, sneezing, lifting something, or even at the beginning after prostatectomy, it's just getting up from a chair. Well, that pushes down and the helper has no idea what to do. So you have to teach the helper to say, okay, every time I get up from my chair, I have to squeeze my muscles. I have to do my pelvic floor contraction. So yes, you trained your muscle for it to be in good shape, but now you're telling your muscle when and what it's supposed to do. Every time you cough, you have to squeeze first. Every time you lift something, you have to squeeze first. Every time you lift your leg to put your socks on, you have to squeeze. So it's a constant thing so that it becomes automatic. And it does become automatic. It's just that it has to learn what to do. So that's with an effort. So things like, you know, bending down, coughing, getting out of the car. There's so many instances, especially at the beginning after the prostatectomy, the effort are small and they cause leakage. But then as the muscle gets used to it, then it will take some bigger efforts. So this is what we're trying to do, is we're trying to train the sphincter to know what to do. So the one that was removed is the sphincter that was, you had no control over that sphincter, but it worked all the time. The one that's left is the one that we have control over it. We can squeeze it. Like when you stop the urine flow, you squeeze the helper. So you're squeezing that sphincter, but it needs some help to be able to know what to do. So the other one that I was talking about is after prostatectomy and after, I'll talk about the radiation a little bit later, you have these bladder spasms, unfortunately. So the bladder spasms are coming at any time. You cannot say, oh, I'll stop having bladder spasms. There are things you can do, but that's the hard thing, is that they can come, you could be sitting and then all of a sudden, oh, that starts to leak. You could be standing and that starts to leak. So it's important to work on those spasms because it's what we call a hyperactive bladder. Now, just think that before the surgery, there was the sphincter number 1. There's the sphincter number 2 that we don't lose. That's good. But there was also the prostate. And sometimes the prostate was a little large. But even if it wasn't, the prostate was also applying a pressure on the urethra. So that was helping continence. It was helping to keep the urine into the bladder. So you had the sphincter number 1, you had the prostate, and the sphincter number 2. Take the sphincter number 1 away, the prostate away, my gosh, the helper there is going, I can't believe, like I'm the only one working here, right? So now, before the bladder would have to really push against the prostate, but now it's like you've made a highway with this way. So it's easy for the urine to come out. And this little helper is going, I can't do it. So there are things that we have to do to try to get the bladder to relax and not go into these spasms. Easier said than done. So number 1 thing, everybody, when they have incontinence, what do? They go to the bathroom often because they're like, okay, I have to empty my bladder. The more I empty my bladder, the less there's going to be in there, and I have less chances of having incontinence. But then what happens is that when you empty your bladder, it's always small and almost contracted. So it's like it's never stretching. So it's learning to do these spasms because you go to the bathroom, you empty it. It fills up a little bit, you go empty it. It fills up a little bit, you go empty it. So you're teaching your bladder all the time to do these spasms and increase this urge incontinence. So we've got to do the opposite. As soon as it starts to leak, because there's like you're sitting and it starts leaking, or you're standing and it starts leaking, it has to be stopped. You're telling your bladder, no, we don't play that game. You have to stop doing these spasms. So it's a constant reminder to your bladder that we don't do these spasms. And it's an interesting thing too, because there is an inhibition from the brain that goes on to the bladder. And you see that with women much more than men. When you're sitting at a restaurant and there's some women and one says, oh, I have to go to the bathroom. Would you like to come? And she, oh yeah, I'll go because I think I have to go. So the fact that you think about it, it makes the bladder contract more. So somebody that's like saying, oh, I better go because I went an hour ago and now I think I should go. You increase the spasm again because then the brain is not inhibiting the bladder. So there's a couple of other systems that help to relax the bladder. So this is really important, not to empty often and to let the bladder fill up, because if we don't let it fill up, we will keep getting those spasms. It has to start filling up. So by using the same pelvic floor muscles that we will talk about in a sec, you're going to help to get the bladder to relax. But it's some work. It's not as easy as it sounds. Now, there are other things that will make the bladder go into spasm. And, unfortunately, it's things that we like, right? Coffee and tea. So all those things will increase the bladder spasms. So as much as possible, when there's incontinence, we have to really reduce the caffeine. And caffeine from Coke, from Pepsi, is also something that should be reduced. So like I said before, you can have incontinence from a few drops to quite a bit. So that's the one thing. In the beginning, after a prostatectomy, one thing that should be done in the first month to try to fill up the bladder so that it doesn't go into these spasms is really to lie down, because lying down is the best position to fill up the bladder. So we tell people in the afternoon, you should take a nap. You don't have to sleep, but you have to lie down so that you get your bladder to fill up. Because if you're always sitting or always standing, it does not, standing is the worst position after prostatectomy because it won't be able to hold anything. The helper is not able to work in standing yet. It has to learn to work lying down first, then sitting, then standing. So I'm not saying that you have to lie all day. That's not a good idea because you have to move and walk. But making sure that you spend, let's say, an hour in the afternoon to be able to get the bladder to fill up a little bit and not be into all these spasms. And it seems that it's the afternoon that's always the worst time. For some reason, the incontinence is better in the morning, the worse in the afternoon, like 11, 12 to 6, and then evenings are better. So we're not understanding exactly why, but that seems to be a pattern that we always see. So what else could reduce, well, how could you reduce the incontinence? It's the muscles, because the helper is a muscle. It's a voluntary muscle, just like your bicep, just like your legs. And if you don't exercise it, or if you don't tell it how to work, then it's not going to work. So we need to get the muscle going. And how do you do that? You have to be able to contract the muscle without increasing the abdominal pressure. So if I'm doing a contraction and I'm really squeezing hard, I just increase the abdominal pressure. So I'm actually like doing the opposite of what I should be doing. So I'm doing a contraction now and I can still talk to you. And you can't notice if I'm relaxing or if I'm contracting, because that's how it should be. The pelvic floor muscles are muscles that we should be able to contract by sort of as if you are contracting. It's easier to talk about lifting the anus up or trying to stop the urine flow. We try now to get, and you're going to find that's funny, you try to get the penis to come in as if it's the head of the turtle trying to go in. That's also another way of getting the contraction to happen at where the sphincter is. So lifting the anus up, holding for about 5 seconds, relaxing 10 seconds. But that's only to train the muscle. Now, if I'm going to be getting up from a chair, that's the exercise I have to do. If I'm going to bend down to pick up something, as I bend down, like before I bend down, I have to squeeze and then bend down. If I'm going to put boots on or socks, I have to squeeze and then lift the leg, because this is when the leakage will happen. That's the stress incontinence, right? So let's say I cough and I've contracted, and then I'll stop. I cough, I contracted, I held the incontinence, there was no leak. I relax my muscle. Then all of a sudden, about 10 seconds later, there's like drip, drip, drip. That's because the effort on the bladder made it nervous, and then it went into a spasm. You have to stop that. You have to say, no, I said we don't do that. You tell your bladder, we don't do this leaking like that. I have to stop it. So you do your contraction again until it stops. If it takes a little bit of squeezing, then fine, but you hold it to tell your bladder, we don't do that. And then relax slowly, and then often the leakage stops. So these are two different strategies. One is to do it during the effort, and the other one is to stop when the bladder goes into a spasm. And the more you train your muscle and you train to do it that way, the easier and the faster the incontinence will go away. And the more you're going to be able to hold in your bladder. So people tell me, yeah, but the more urine I have in my bladder, the more incontinence I'm going to have. And if you think about it, most men after a prostatectomy, let's say a few weeks after the catheter is out, the best time they can hold is usually when there's urine in their bladder, like in the morning. They can usually make it from the bed to the bathroom. And that's when there's urine in the bladder. The times that are the hardest is when you go to the bathroom, and then after, it's like, my gosh, I went to the bathroom and now it keeps wanting to empty, like drop, drop, drop. So that's the time that the bladder starts to be nervous because you taught it to squeeze now to empty. So these are all things that you have to say, no, 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 it has to stay inside. You go to the bathroom, then you stop that leaking afterwards. You just don't let it leak. So what I was saying is the exercises, I went ahead and explained that to you. The exercises, when you do them, you should never force. It should be either around the anus or at the base of the penis, trying to bring the penis in. And we hold 5 seconds, relax 10 seconds, and you can do about 10 times in a row. But that is to train the muscles so that you understand how to get it. But if I'm going to cough, I don't need to hold all of that. If I'm coughing, if I'm doing an activity, then I just squeeze the time of the activity. Well, at the beginning, it's probably lying down and sitting. And then when it's easier to do the exercises or it's easier to contract and not using the abdominals, then I would say to do them in sitting and standing, because we have to use them in standing a lot because we do things in standing. So it's good to start exercising them in different positions, but at the beginning, people tend to use a lot of stomach if they're doing them in standing. So lying down and sitting. But again, I would still say, even if you practice your exercises lying down and sitting, if you're coughing in standing, then you do your contraction, right? You're going to squeeze. So that, and you'll see this is on this slide, it's called the knack. You have to get the knack of doing it. So when you do an effort, you have to get the knack of contracting your muscle. That's why they named it the knack. So it's really a locking. You're locking your muscle before the activity. So you practice them, and then you practice them in sitting and lying down, and then you use them in any position. So I would say I have so many people that come pre-op. We explain all the exercises, we explain the knack, and then we see them after and they're like, I've been doing my exercises and it's not working. I still leak. Well, that's because they forgot about the knack. So if there's one thing to remember, I don't care if you don't do any exercises, you need to do the knack. That's the one that will stop the incontinence with effort. And then the other one will be for the urge. But this is your most important exercise or activity to do. And then for the leakage, that's more the drip, drip, drip anytime. It's just getting your muscle to say, no, we don't do that. And you calm your bladder down, because the bladder gets nervous after a prostatectomy, but as we will see, it gets nervous after radiation. Decreasing your caffeine is going to be a very important one for the urge incontinence. The other thing to do is what is called a voiding diary. So if you write down the time that you went to the bathroom and how much in the volume, then you can see, oh, am I going for very little? And am I going often? Because sometimes we don't remember when we went to the bathroom. So when you write it down and you measure the quantity and you see that you only have a quarter of a cup, or like less than 100 milliliters, that's not good. A bladder should contain 350 milliliters. So that would be about over a cup, right? So when you go, you should not go for a small quantity. You should have been able to hold it. And that's a way of knowing, am I going too often? So the normal in a day is about, so it's written on the next one, a normal in a day is about 5 to 8 times a day to go to the bathroom. So if you're going 10 to 12, you're going too often. You have to start using your muscles to push the urge away and to wait a little bit, because we need a good quantity to be able to empty properly and to be able to stretch the bladder. So the voiding diary is actually a really good tool and gives you a lot of information, and it doesn't take much. I mean, you just get yourself a cup from the dollar store, and then you measure the urine that you pee, and then that will give you an idea of how much you have in your bladder. Because, you know, we always say, I'll have the comment to say, oh yeah, but there was urine in my bladder. But when you think about it, 100 milliliters that you're pouring out, it sounds like there's quite a bit, but it's not enough. So a lot of people, what they do when they have leakage is they stop drinking water, or they reduce the amount of water. That's not good either, because if the urine is too concentrated, it will actually make the bladder more nervous. And if you tend to drink your water fast, it's going to make your bladder nervous as well. So it's not a good idea to say, oh, I forgot to drink today, I'm going to drink it all at once. So someone should drink more like regularly. And what is the normal in a day? It's about 4 to 6 glasses of water. So it's not like a huge amount of water, but it's enough. You have to drink, you have to put water, you have to drink water to put urine in your bladder for it to hold. So people that are not drinking enough, they make their bladder more nervous as well. So that's another thing to think about, is to start drinking, and drinking it like gradually through the day. So if we look at what we talked about, we had, you can look at the voiding diary to see when you're going and quantities. Diet modification, decreasing the coffee and the tea, that makes a big difference. I mean, if you still want to drink coffee, maybe going to decaf for a while would help, because it's going to calm the bladder down. Doing your exercises so that you're good to do the NAC, and you're good to be able to get your spasm, to stop the spasms. And then I'll talk about, oh yeah, this one. So the other things that could help is the clamp. So a penile clamp, I don't use it. I don't recommend the penile clamp as something you would wear all day. It's for people that have a lot of spasm in their bladder. And then what we can do is, let's say you can hold for an hour, and after an hour, you start to feel that either it's going to leak, or it's going to start giving you urges. So that's the time to put the clamp to stretch your time a little bit and say, well, maybe I could go another 15 minutes, half an hour, to be able to get my bladder to stretch a little bit. I don't know if you understand what I mean, is you're trying to stretch the amount of time between the times you go to the bathroom, but not to wear the clamp and say, oh, I have the clamp, I don't need to work. That's not the goal, because then like your muscle will get lazy, you're not working on it, and you're using the clamp to instead of training the helper. So the clamp is to help a little bit more and say, okay, I'm going to try to push my bladder a little bit. And if it's another 15 minutes, 20 minutes, half an hour, maybe an hour, and then I tried to do that. And then hopefully by doing that, you start to stretch it and your bladder can hold for 2 hours. And then after a while, it can hold for maybe 2.5 hours. So I would use the clamp more for that than as a real, like an all-day treatment and say, I'm not going to work on the muscle, or I won't work on the spasms. Okay. So what happens after there's brachytherapy or an external beam radiation is there's not as much of the stress incontinence. We don't see that as much, but we see more the problems with a nervous bladder, with the spasms of the bladder, these urges that are so difficult to hold because they're getting really urgent. So this is how the bladder usually reacts, is by doing those spasms. So everything I have been saying will apply. The only difference between people that had a prostatectomy and getting these this incontinence is that they don't feel the urges as much. Men that will get the radiotherapy, they get these urges that become so urgent that they feel the urgency. So that's harder to hold, but they should work on it the same way to try to get the muscle to inhibit the bladder. So when we squeeze the muscle, we inhibit the bladder, and then it helps to maybe make it a little bit more. So it's that is trying to get that stretching of the bladder as well. But you can't say, oh, I'm going to hold it for an hour now. No, you have to work like 10 minutes, 15 minutes at a time, and to try to push it a little bit to get the spasms to decrease. So that's really the way to try, and then decreasing again with all the decreasing your caffeine, everything that would make the bladder nervous. So the same thing applies to use your pelvic floor muscles. So when we use our pelvic floor muscles, I'll give you an example. When you're going to the bathroom and you stop the flow, that's because you used your voluntary sphincter. It stopped the bladder from contracting. So that's how the flow stops. If then you relax your sphincter, then the bladder starts contracting again, and then you can continue to go to the bathroom to empty your bladder. So this inhibition happens when we squeeze our muscle, and then it goes to inhibit the bladder, and the bladder relaxes, and it says, okay, I'll wait until you want me to continue. So this is how we can train the bladder to be less nervous. And then, of course, more volume. So in physio now, there's been much more research that is recommending that men come for an appointment pre-op so that they learn what to do, because there's a difference between contracting your muscle before surgery and after surgery, before radiation, after radiation. The reason is that before, you don't have to worry about the incontinence. You don't have to worry about the spasm of the bladder, or not so much, maybe a little bit for those that have a hyperplasia, if their prostate is bigger, but it's not the same as after. When you have incontinence, it's so debilitating at the beginning because it's like an all or none. All of a sudden it starts leaking, and men are not prepared. So then first of all, knowing how to deal with it, what they should be doing, when they should be starting, because often you don't get to physiotherapy, like let's say a week after the catheter is out. So you can start the exercises, and then they learn how to start them and to know what to do. So that seems to have made a difference, and a lot of the research is showing that too. And then some visits after, we don't tend to see men many times because it's just a matter of teaching people what to do, and then they have to practice it at home, but they have to do it. And unfortunately, we can't do it for them. So it's really important to discuss the types of incontinence and how you can stop it. Now, the other thing that now is being done more, and it wasn't before, and I think I attended the Zoom meeting with Dr. O B Peterkin, and she did talk about this, which I was so pleased, because not that many urologists are actually starting to do the penile rehab. And I think that is something that they will have to start doing it, because Australia does it quite not aggressively, that's not the right word, but early after the prostatectomy. You have in England, they do it like maybe a week after the catheter is out, is to start to do penile rehab, and that's how they call it, with a vacuum pump and a medication like Cialis at a low dose. So the idea is now a lot more urologists are starting to use the Cialis at low dose early. So what it does is that it's to bring blood into the penis so that you're keeping the penile tissue in good shape for when the erections will come back again. And they have seen some very interesting research that's showing that it helps. So getting the blood to the penis with the Cialis, with the medication, will help. But then they found that doing the vacuum pump is you're pumping more blood. So it's the way I explain it to the men that come to see us is to say, it's like, you know, you have your sponge in the kitchen and you leave it on the counter and it's going to dry up and it's going to be pretty dry. Now, to put water into it, it takes quite a bit of water for it to start expanding. But if you took your sponge and put a little bit of water in it every day, your sponge is going to stay much easier. Like it's going to be more pliable. It's going to be more spongy and not so hard, right? So this is what happens with the penile tissue. If there's no erection, if there's no blood coming, if the penis doesn't get filled with blood, then the tissue has it will get more, it's more difficult to actually get the erection after when the blood wants to come in. So the idea of, yes, the Cialis or the medication, usually they'll use Cialis because they're using it at 5 milligrams. Some doctors now are going to the 25 milligrams, but it's the idea of taking it every day and doing the penile rehab about 5 to 7 times a week. And there's a certain protocol to do to actually bring the blood into it. So it's not necessarily using the pump to be able to have intercourse. It's more using the pump to bring blood into the penile tissue. So that's the newer thing. And that's what it says, 5 to 7 times a week. And what we're doing is the protocol is done in a certain way that you have to do so many minutes of keeping the blood into the penis, then decreasing it, then increasing it again. So it's not just use. I know some men will use the vacuum pump after to be able to have an erection, to have intercourse, but this is actually more used to getting the blood into the penis every day and working at keeping the tissue in good health so that when the erection comes back on its own, then the tissue is ready for it. So it's good to see that that urologists are starting to actually use it here. And we have chosen at the clinic, we've chosen to use the VacuRec pump only because it's a little bit less cost. It's still costly, but it's less costly than the electric or the battery operated one. And we find too, that's the one that quite a bit of research has been done with, but we find too that the control is maybe a little bit easier because the other one, it's kind of you have to press the button, and sometimes when like it can start to not hurt, but just not fill the right way. Anyway, you have to get used to the pump anyway. No matter which pump that you're using, there's a certain amount of time that you have to use it to get used to it. But this is again the newer thing that is being done. Yes. If there's a time that will be ineffective, they say the best is to start within about 6 months after, like within 6 months after surgery. The men that have some filling afterwards, it could still help. But somebody that, let's say, had no erections, no filling at all, like no what we call tumescence, like the beginning of an erection, even though if it's not a full erection, if somebody has nothing, then past the 6 months to a year, it's not going to work as much. They do say that it could, like the studies that they've done in Australia and England, they do say that it could take, like you may have to do this for like a year and a half to keep the penile tissue in good health. So it's not something, they have really found that it was worth it to continue doing it. But is it, they haven't done that much research on men starting it later than that. Hasn't been studied yet.
And this is the problem here is a lot of doctors, you're saying that some of them are starting now, and we've met with and spoken to many doctors here, and there's not that big a pool, and it's not as common as you're making it sound,
I
I
know.
think.
Oh no, it's just I've met with a few urologists recently, and they're just like, oh yeah, okay, so we're gonna start to do that. I'm not sure why not. Like I know Dr. Obi Peterkin was talking about it, and I was so
Yes.
pleased because I hadn't some other urologists I had not heard that from them yet. But
But
it'll come.
at the Glen, there's only two doctors who are doing erectile dysfunction work. And one is Dr. Chan and the other is Dr. Carrier. And she's not one of them who's actually doing this. So she might be willing to do it, but she's not actually one of the ones who's actually meeting with patients.
Yeah. No, and that's true. I would say that, like, for example, at the Lakeshore, they have people coming to our clinic. So for us to teach them how to do what the protocol is, how to specifically use the pump and all that. Yeah. But but again, each urologist has their own ideas to when they want to start it. I'm telling you what the research says, but whatever the urologist feels comfortable with, and that is not my decision. It's the surgeon that did the surgery.
And the second part to that is that to get to see the doctor to actually do whether you want to do, they don't push the pump. They will talk about either the implants or doing the injections. But it can take 6 months to a year to see the doctor to get that done.
True. That's right.
Can everybody hear Neil?
Yeah. Oh, sorry, guys. I hope you guys online can hear me. I'm trying a new microphone here.
Yeah. So yes. So I think this is like the thing of the future because it's very new, and more urologists will start to know about it and hear about the research. And I think it will. But they're just starting they haven't been introduced to it yet, so it's not. And it's interesting because I mean, I saw all this research, and the person that was presenting it from Australia, and her study came out 3-4 years ago, I think. And she presented that like the first summer of COVID, so 2020. So that's already 2 years and a bit. But with COVID, I think things have kind of slowed down a little bit for research because people haven't been going to conferences as much, like doctors. But I think it's going to be something that they will. It was always okay. We'll get rid of the cancer. Okay, now there's incontinence. We'll get rid of the incontinence, and then we'll deal with the erectile dysfunction. Now the idea is more like, okay, we're going to get rid of the cancer, but then we deal with incontinence and the erectile dysfunction right away. So because you can start this kind of protocol with the pump, even if there's incontinence. It's not to have intercourse. It's really to be able to just keep the penis in good health, like the tissue in good health, to bring vascularization to the penile tissue. So I think it's going to start to really change. And I think if more men talk about it too, that it will help, because I think what happens a lot is men feel that they want to get rid of the incontinence first, and I'll deal with the erectile dysfunction after. And we hear that. We will talk about it in the pre-op visit, and we will say the risk of the incontinence and the risk of erectile dysfunction. And the comment we get with almost everybody is, "Oh, but that's okay. That's okay. I don't need the erection. I just want to get the cancer out, and I'll deal with the incontinence. That's okay. But the erectile dysfunction, they'll put it aside right away." And we're like, no, you need to think about it like soon after, because the chances of having it come back is if you do something sooner after the surgery. Yep.
Like books in front of me, in front of my erection, because I was embarrassed. So for men, of course, it's just being so automatic, and all of a sudden we're dealing with this, and well, it has a whole thing with manhood, and
Yep.
it's a whole psychological thing.
For sure.
We've been brought up
Yes. And the other thing too is you have to work at getting the erections back where you didn't have to before. So that's a big thing, is to think, wow, I have to do all this work to get the erections back. Yeah. Yes.
Just a regular dietitian.
I think a regular dietitian would help, but I would pick a dietitian that works more with gut issues like IBS, or because what you're saying actually is, and this is very common in just not even just with prostate cancer, but when we have constipation issues or we have IBS, like irritable bowel syndrome, it affects the bladder. It will affect the urgency. It will affect, so if somebody has urgency and had a prostate surgery, well, then of course, anything that of the foods that affect the colon, that will affect the intestine, will have an effect on the bladder and maybe cause some problems. So that's why I would say I would pick a dietitian that has training for more like the irritable bowel syndrome, the food, not allergies, but food intolerances, which in the general population will cause bladder issues. So this is really a good point, because some people will find that on top of these, like for example, some people will have sparkling water that really affects their bladder. It gives them a lot of spasms. So we think, oh, okay, I'm not drinking Coke, but I'll have a Perrier or whatever. And that will cause more bladder issues. Some people with the dairy products, like you're saying, but that's usually from the IBS, like irritable bowel syndrome. Yep. So yes, absolutely. That's one of the medication that will help to decrease the spasms. So there's two types of medication. There's what they call the anticholinergic medication, and Myrbetriq is the other type of medication. There's only one. There's many of the anticholinergic, Detrol, Ditropan, Trozac, whatever. But those cause a lot of dry mouth. So they've come up with a newer one. It's called Myrbetriq, and it doesn't affect the same way, so you don't get the dry mouth and all of that. So this is a medication, but if you read on the monography, or whatever it's called, of the all the instruction of the medication, it will tell you that you have to do pelvic floor exercises. So behavioral techniques, which means that you have to work on your brain, and you have to work on decreasing those spasms for the medication to work. Okay, so this was just the last slide to say that you really need to, I think you need to take charge and look after your own incontinence and do something, because there's something that can be done. You can reach a physiotherapist through the OPPQ. If you, depending on where you are, there are trained physiotherapists that can help for this type of problem. And like I said, we try not to have people come once before, and they'll come after one time, twice, depending on the problem. But the idea is to just give as much instruction that people can work on it, and then they work on it at home. So thank you.
Q&A. Are there any questions here as well as on Zoom, Neil?
I have a question.
Meantime, are there any questions here in the room?
When you're using the pump, are you using non-oxygenated blood to go into the penis?
Obviously, it works.
Okay.
Okay.
To speak like over here.
Yeah, you can just clip it in.
Okay.
So you mute it.
Yeah, these are not reading glasses. Yeah.
I'll be in charge of this.
Yes. Oh,
I went too far away. Did we lose power? Or,
You only have to touch it quickly. Did you turn it off?
I might have.
It's off button, the upper button.
Yeah, I did, and it just went when I touched the upper button, it went off.
yes.
Steve broke.
We'll answer the question in the back. The prostatectomy. So radiation therapy, yes. So in relation to incontinence, what's the average recovery time for someone that had radiotherapy compared to the surgery? The radiotherapy is, there's less data on it because it is very varied. It will vary quite a bit depending on how the person reacts to it. So it's mainly bladder spasms, and bladder spasms are the hardest one of the two incontinence to get rid of. So it's basically 6 months to a year.
I'm asking the question because I'm going through it right now. Week 19 out of 22.
Okay.
So I'm going to finish on that. 2 days. When I started at first,
Okay.
the first meeting, the second,
This is, it shows that it's recording
there
right
was
now.
no
So you just leave it like that.
pressure, no urgency. Boy,
Yep.
I started to, third week, I started to realize that the radial mappers living up inside strong abdominals. I have strong abdominals, but I couldn't deal with the pressure that I was getting in my bladder.
Mm-hmm.
I thought I was gonna lose it. I thought I was like ready to fall over.
Yeah, but unfortunately, until you finish the treatments, it's not going to get better.
And as they say, as you get close to the end of your treatment, because the radiation is actually irritating
Yep.
the bowel, the bladder,
Yes.
and it takes time to recover.
Yes, it does. It takes time to recover.
So what do you do in the meantime? I mean, do what you said.
You have exactly. You have to try keep working on it, but it won't work 100%. It's not. The little gains that you can have, the keeping in mind that you're trying to decrease the spasm of the bladder is what you have to do. But knowing that it's not going to get better. First of all, it won't get better until the radiotherapy is finished, and then after it takes a while for it to recover.
I need to find a while. I understand.
6 months to a year. Yeah. Yeah.
I got one to build on his question. I didn't have any problems right after the radiation. It started in 6 months after.
Oh, it did?
Yeah,
That
6 months, and then did it ever set in?
okay.
They had damaged the sphincter. I saw that in the cystoscopy myself. It had all, it's like alligator skin with blood in between.
Okay.
And I started bleeding from my rectum. And it progressed. I'm getting better now. I'm not bleeding as much. And I have exactly the symptoms. I wish I'd seen the presentation 6 months ago.
I had a radical prostatectomy about 19 months ago.
Yep.
And ever since, I've had very severe leaking, like extremely severe. And I've actually gone to a physio twice, a different physio. And each time the leaking got worse.
Oh, that's not supposed to.
Well,
It's not supposed
I
to.
know. But,
So my guess, and I don't know, but my guess is that you're doing your exercises too hard. When someone does their exercises and are actually contracting their stomach, you will increase the incontinence. So the
I
contraction,
mean, I was at the physio and they saw what I was doing and they didn't really say anything. So presumably I'm doing it correctly.
well, I hope so. So what you have to do is you have to do the knack. Are you doing that?
Not so much, but it seems like when I get up, I do leak, but I'm leaking all the time, basically. As far as I can tell, almost all the time.
So you see, this is an example that I would say, and that's really what we say. You need to go around the house and remove your pad and know when you're leaking. Because the saying that you're leaking all the time, so when you're sitting, I would not wear anything and be with a let's say a pad on the chair you're sitting, like.
I'm not using a pad, I'm using diapers.
Yeah, but what I mean is buy like doggy pee-pee pads, okay? And you sit on that to see when there is leakage. You have to see when the leakage is happening. Is it a drip, like drip, drip, drip? And then you have to stop that. Because if you just let it drip, it's going to continue to drip. But when you're wearing a pad, the bigger the pad, the less you feel the incontinence, but you see it in your pad, but you don't feel when it happens. So you have to wear either a very small pad, or when you're sitting on, I don't know, on your couch at the computer chair, whatever, you don't wear anything. Like you put a pee-pee pad for a dog under, and you look when it's leaking. And when it leaks, you go, no, I have to hold that. Do you see what I mean? Because if you're wearing a pad, you only know you're leaking because it goes in the pad.
When I'm in the shower, I'm by myself, I'm leaking.
That's right. That's because you can see it and you can feel it because you don't have a pad.
Right.
So in the shower, you have to stop it. You don't let it leak. You use your muscles to contract and not let it leak. That's the trick.
So is there a point to continuing with the physiotherapist? I mean,
Well, it should not get worse. It should not get worse. That's for sure.
well, it did. I mean, I measure it. It's
You measured the leakage?
yeah.
Yeah. So yeah, it should not get worse because you should be able to hold more urine in your bladder.
I mean, normally I can't urinate during the day most of the time.
You can't what, sorry?
I can't urinate during the day.
Because it leaks into your pad.
Yeah, all the time.
Right, yeah.
Yeah.
So that's what I would do anytime, not when you're standing, because it would be every time you're sitting, I would not wear anything and see when it's leaking and you need to stop it.
Because also you mentioned that in the afternoon it seems worse than the morning, but in the evening it seems worse than the afternoon.
That's because maybe the muscle is more tired. So sometimes it gets better, usually it gets better in the evening because people are more sitting. But if it's getting worse in the evening, it's because your bladder is very nervous. So if you were seeing me, I would say soon, I would talk to the urologist to see if using a clamp would help for like trying to fill up your bladder a little bit. Not all day, but just starting to use a clamp.
But the surgeon who did the prostatectomy, he said in the first 12 months, he just said have patience. And then he told me, well, you need an AUS.
I know, but you can work on that. You can work on it now.
So I have an appointment. I've seen Dr. Obe a couple of times and I have an appointment with her next month. But she also sort of intimated that I would need an AUS.
Well, you may, but maybe in the meantime, you should work on it because you have better success with an artificial sphincter when you're not leaking as much. The more you leak, the less chances that your artificial sphincter will work. So that's why it's worth working on it. Definitely.
Okay.
Yeah.
Next question. Okay. Can you go ahead?
I have a different type of question. I've had brachytherapy and external beam treatment last December.
Yeah.
And now I'm trying to deal with erectile dysfunction. And my urologist prescribed, tamsulosin.
Yeah.
And we started with Cialis, 5 milligrams.
Okay.
And after taking Cialis for about 3 weeks, 2-3 weeks, all of a sudden now I'm having heartburn all the time.
Oh, yeah,
Have
it
you
does
heard-
that.
Is that a common
It is.
side effect of Cialis?
Yeah.
And it's very disturbing. It's
Oh, yeah.
disturbing than anything else, you know? So what do you do? Stop taking Cialis?
Yeah, I would go with the pump.
The pump.
Yeah, I would go with the pump
Okay.
and stop your Cialis because,
All right, so.
you
if
know,
I'm
I mean, to
leaving-
talk to the doctor about the Cialis, did you speak to the doctor?
No, I've been trying to figure out what the hell's going on. I know
Yeah.
a penny dropped a couple of days ago.
Yeah.
That started when.
Some people do have that as a side effect.
So then to start with the pump, should start doing that quickly, right? You know, like,
Yeah,
because
as,
and
as soon as
I'm leaving on the
possible.
weekend for 4 months down in Florida. So
Oh.
I don't know what should I do?
Buy it in Florida.
Yeah, exactly. Yeah.
Yeah.
Yeah, what should you do? Well, for sure, 4 months is a long time if you don't do any, like if you're not taking Cialis and if you're not doing the pump.
Yeah.
Right? Because the pump brings the blood, the Cialis is trying to bring blood, you know, that's the same.
So if I wanted to buy a pump, what do I do? Go to Amazon? It's like,
No,
No.
so be careful with the pumps though, because you really need a medical pump and not, the ones can cause bleeding, can cause bruising. The ones that often you buy in a sex shop or you buy on Amazon, those are the things.
so
you need,
you have one that you recommend though?
we work with the VacuRec, the one that was in the picture there,
How do you spell?
VacuRec.
VacuRec. It's VacuRect. VacuRec.
Okay, good.
Yeah.
Yeah, do you need a prescription to get it?
No, you don't.
You need a lot of cash.
But I think it's 225 plus tax.
Okay.
That's not bad. That's not
The
bad.
electric one, I forget the name of.
And then you're gonna sell on Amazon. Okay, all right.
Great, okay, so that's all right.
The ones that are electric, because this one's manual, right? The one that's electric is more expensive. I think it's in the 400.
But you were saying though, the manual, you seem to have a little more control over it. so
Yeah,
prefer-
yeah. And like a urologist was saying, it also feels like masturbation. So it's also a little bit more, you know, it doesn't feel that you're doing something that's
It's more natural.
Yeah, exactly. It's
My
yeah.
urologist said go to a sex store.
No, that's the thing to be careful is because some of those pumps are.
Mhm.
The other thing is when you have a pump, there's a ring that you have to wear. And those rings are made to go on the pump and they're medically, and that's what keeps the blood into the penis, right? Well, the ones that are in the sex shop are what they call the cock rings can be very hard and they could bruise quite a bit. So that's the part that, so it's not recommended to buy those and yeah,
Thank you.
you're
We'll
welcome.
cover this section and we'll go over there, okay? Go ahead, sir.
A couple of things. You were speaking earlier about some drug beginning with an M,
Mirabitric.
and so that's for incontinence or penile
Yes.
rehab?
No,
or
it's for
gastro-
incontinence. It's for incontinence.
Oh.
It's for nervous bladders. So when people have like the urgency or they have the leakage that happens not with an effort, then taking Mirabitric. Mirabitric is the name of the company, like the company name. So the molecule is mirabegron. That's the name of the medication.
Okay, so if you're not having a problem, then you just wouldn't use that.
No.
It has nothing to do with the irritable bowel syndrome you were
No,
talking about?
well, no, I would work on the bowel instead of
This is
taking
not-
that.
This is not an over-the-counter medication.
No,
It has
no,
to be
no, no.
prescribed.
It has to be
So,
prescribed by the
so you'd have
doctor.
to see a urologist.
Yes,
and what-
urologist or family doctor.
And what you were just saying about this VacuRec,
Yep.
you don't buy it on Amazon. Where do you get it?
Well, so we have been holding it at our clinic. The reason is because it ends up being less expensive because when you can buy it on their website, it comes from the States and you end up paying duty on it. So it's much more expensive. So we order them and then we have them at the clinic.
And do you have to make an appointment for that, or you can just buy it without an appointment?
You can buy it without an appointment. The protocol, I mean, we could send it to you, the protocol for the penile rehab for this because there's different protocol depending on the problem. Like premature ejaculation has a different protocol. Peyronie's disease has a different protocol, and those are all penile problems, right? So this has a certain protocol to like how many minutes you need, at how much percentage of the erected penis you want to get to, like the filling. You want to get 50% of filling and then 75% of filling. So you have to hold the filling for 3 minutes. You have to decrease it for 1 minute, you know, and do that.
Specific.
Yeah,
Okay.
it's specific.
But if you buy one of these things, it comes with those instructions, I guess?
We usually don't put them with the pump, but we can send them to you and they're all written out. Yeah.
Thank you.
Great. Okay, great. Anyone on this side? Last question over here. We'll go over everything. I know, Brian, you haven't had a chance yet.
I had my prostate removed about 4 years ago, and I've had virtually no leaking whatsoever.
That's great.
One bad habit I just realized is that carbonated water on a daily basis. The urination is better since I've had it removed. However, I find at night, I'll still, and for the last 30 years, I've always gotten up 6-7 times. Maybe it's all up here. And I still have that at night. I find now I have a steady flow during the day, but at night, at one single episode, I'll have to stop, go, maybe 4 times.
Do you have sleep apnea?
No.
No? Is there a lot of urine? Because it
No.
sounds like you're not going into deep sleep and your kidneys are not slowing down. When we go to the bathroom a lot at night is because we're not producing enough of this antidiuretic hormone. We produce that when we go into deep sleep. If we don't go into deep sleep, we don't produce it as much. So then the kidneys continue to produce urine and then we get up more often. That's why I said if you had sleep apnea or you're not sleeping well enough to get into deep sleep, so you're going to get up more.
Well, I find if it is, like you say, a light sleep, I tend to get up more. But if I do actually go into a deep sleep, by the time I'm ready to urinate, it's much greater, stronger.
Right. The reason you're having a hard time is because there's not enough urine in your bladder, but your bladder is giving you the impression
Spasms.
that you have a lot of, the bladder doesn't know anything. Like it doesn't know that it has a lot of urine or a little, it is. All it wants is to contract, right? So it has no idea. So it's like it contracts as if it's full and there's like this much in it. But then you're going to have a hard time to actually empty because it can't empty. There's not enough pressure, right? So this is a problem. But so what I would suggest is try to do your exercises, your pelvic floor exercises when you're sleeping and say, no, I'm not getting up. Make it that, I feel so good in bed. Like you have to, don't dwell on the fact that, I have to go. That's not going to work. But you have to say, it's nice and warm in my bed. I don't feel like getting up, that kind of attitude to try and then do your exercises and say, no, that's enough. And do you play golf?
No.
Okay. I was going to say, well, do you like traveling?
Yeah.
No, not really. I was going to say, like, for example, if you play golf, yes to both. If you play golf, then in your mind, clean your clubs one at a time, right? So that you're concentrating on something else and then you're going to fall asleep again. So it would be the idea of, I don't know, do you like repairing your car?
No.
No. Okay.
What I think what you're saying too is a lot of it's up here.
Absolutely. Yes. That's what I was trying to say.
Yeah.
Keep your mind on something
Yeah.
else.
And does radiation have a high percentage of problems with with your?
Can't hear you.
Yeah, it does. As much as the prostatectomy. Yeah,
Okay.
it does.
There's no percentages.
Well, again, they're saying like a wide range. It could
Yeah.
be from 5 to. So for example, if they did a survey and they asked you at 2 months, he would have said, no, everything's fine. So in the research, he goes as, he's in the 65% that don't get any, but at 6 months, he ended up having some, right?
Yeah.
So that's what happens with the research is they have numbers, but it depends when they're asking people and what they're asking as well. So
Just a question for Brian, in terms of how much he drinks before he goes to bed? How important
that
is
that would make a difference too, but you don't want to not drink at all, but still, like not drinking tea in the evening, not drinking coffee in the evening, not having things that have caffeine, and not too many drinks during the evening either.
So less.
But I'm not sure that that's what it is, because otherwise there would be big quantities.
Yeah.
There would be large quantities.
And no sparkling water.
Yeah, well, it could irritate the bladder. Spicy foods will irritate the bladder too.
Nothing to live for, no spice.
I know. No alcohol. Yeah.
Well, you can clean your
No,
clothes.
you can clean your clubs. Yeah.
I can't go on the golf course for 18 holes because I'm gonna have to pee somewhere.
Right.
Okay, we have a question over here.
Yes.
Thank you very much.
Okay.
No problem.
Oh, I think we lost you.
What are the pros and cons of the AUS versus the ATOMS?
I can't really answer that. I think your surgeon would be able to answer that better. Yeah.
Yeah, we have a question in the back here. Go ahead, sir.
I have radiotherapy, and I didn't have any problems with incontinence until after,
Right.
much after,
Okay.
and now I have. I had one question, please. What is the name of your clinic?
We're in Pointe Claire on Donegany. It's called Kinatex, Centre de Santé Pelvienne.
Okay.
Do you know where, are you from the area?
Yeah.
Do you know where Fraser Sports used to be?
Yeah.
Well, we're in there.
You still have the ad for the Suburban?
Yeah.
Yeah, if you check the ad in the Suburban. it
Oh,
says
you haven't had
Kinatex.
in the Suburban?
Well, we put an ad for.
Oh, okay.
Oh, okay.
It's marketed.
Yeah, it's where Fraser Sports used to be.
But I'm very happy I came here tonight. I learned so much about.
Oh, well,
this.
that's good. I'm glad.
Yeah.
I'm glad.
Thank you.
Oh,
Thank you
okay.
very much.
One last question.
One second, go ahead.
I want to open up to the.
Does anybody on Zoom want to ask any questions?
I was just going to say something to Marie-Josée, David Britton from Ottawa, lovely
No,
presentation.
David, sorry, I'm not, hang on a second, David, hang on. No, I know what's the problem. Okay, try again, David.
David Britton from Ottawa, Marie-Josée, a lovely presentation, and I think we'll have to have you do it in Ottawa too. Wonderful.
I have a question. Hello? Can you hear me?
Yes.
Okay, about the pump, I understand the pump brings non-oxygenated blood into the penis.
Yes, it does.
So does non-oxygenated blood help the penis, or?
Yes. Actually, that's a lot of people will say, oh, it's not oxygenated blood, but it's better than not bringing anything at all. So yes, it will help. It would be better if it was regular, like a regular erection. That would be perfect. But this is better than not having any erection.
Because my urologist is not in favor of the pump. I'm on Viagra, a small dose every day, but he would recommend it after a year.
Yeah, I'm not, see, that's the thing, is I'm not sure why they do that, because that's not what the research is showing. So
He may not be up on the research. He may not be up on the research, but I will see him in 3 months and probably push for the pump, delay getting a pump for 3 months, because I am going to Kinatex. And it had been suggested, and I said, well, I'll see my urologist. And now I'll find out in 3. I saw him today and I asked him about the pump, and he wasn't in favor of it. He's more in favor of injection than anything. But I would rather have a pump if it would be beneficial.
Right. So the idea, the difference between the injection and the pump is the pump, you can do it more often, where the injection, you can't really do more than about 3 a week.
Wow.
So That's the problem. And the pump, it does more like regular erections when men have several during the day. So this could be done on a daily basis, but you will not do the injections on a daily basis.
Okay, thank you very much. Food for
You're
thought.
welcome.
Food for thought.
Yeah.
Any?
Yes. What is?
No, sorry, sorry. Anybody else on Zoom have any other questions? No? Okay, go ahead.
Okay. I wonder what is the maximum time you can put the clamp on to it?
Okay, so you
keep
mean
it on?
at a time?
Yes.
Yes. So you should go with, okay, if you're using it because you have no control and you've tried and it's been years and it's not working, then you can use the pump, not the pump, sorry, the clamp as to hold the urine. Then you would do as if it's normally how many times you would go to the bathroom. So you would wear it for about 3 hours, go to the bathroom, put it back on, go to the bathroom. So we don't recommend that at the beginning if you've done, but if you've done everything else and it's not working, but the clamp is helping, that's how I would use it. But somebody that would use it like that at the beginning would not be working on their muscle and they have a chance that it never gets better. But if it's been too long, then you would work, you would do it as if, okay, I'm putting it in between every time I have to go to the bathroom. So every 3 to 4 hours.
3 to 4. I can't go through a movie without.
What kind of movie you watching?
Where we, the Maverick movie there. It was 2.5 hours. That movie. I wasn't the only one. A whole bunch of people.
Where we can get it?
So the clamp you can get on the internet. You can get it from their website. I like the dribble stop because I find that it has many adjustments. So you can change the sides. You can make it smaller or bigger. The cushion is pretty good too. You get 2 for the price. The Wiser one is also a good one, but you only get 1 for the price. So it's kind of nice to have 2 if it gets, urine on it and you need to clean
You
it.
don't have it at the clinic?
Yes, we do.
You do?
Yeah, we do.
Okay.
Yeah. So we're able to sell it. I forget, it just went down in price. How many things have gone down? Eh? So yeah,
Wow.
forget it went down. It used to be, if you bought it on the website, it was something like $100 or $90 or $100. And now it's come down a little bit. So yeah, so then, but we have them at the, yeah. So that one is the cuff is a little tough to organize. So that's the part that, so the other thing you have to be, no, it's not that one. This is a different one. This is a dribble stop, this one right here.
Okay.
And that's the Weisner. Oops. So yeah, you see it's gone down in price, which is nice.
69.
Yeah.
No Black Friday sales though.
No, exactly.
You gotta wait. Today, tomorrow's Friday. Maybe. Yeah, I think it's a good question. But in terms of wearing a clamp, can you overwear a clamp, like wear it for too long a time?
You could if you go for like
Damage?
6 hours.
Yeah,
Yes,
you can
definitely
actually
you
have
can
stuff
wear
on
it.
back and-
Yeah.
Yeah, okay.
Yeah, you don't want to wear it, just like we should not hold our bladder for more than about 4 hours. You should not hold the clamp, like have the clamp on for longer.
It's good to know.
I had radiotherapy after 16 years of the prostatectomy. And during the radiotherapy, the incontinence was much less during the period and few weeks after. And then started to increase. Now it is after 10 months. Now it's about double or triple. That's why I start to think about the clamp, at least and I wonder if Kegel
Yeah,
exercise would help after
I would
that?
actually use the clamp, which you're describing is I would use the clamp to just start wearing it. Like you go to the bathroom, you see how long you can go without starting to have incontinence. And then you put the clamp on for maybe a half hour or an hour. and then you go to the bathroom again. So you're trying to stretch the time slowly, but I would start without wearing it, then you put it on. Do you know what I mean? Like an hour later or half an hour later, when it starts to, because it sounds like you have urge incontinence, not stress incontinence. So you need to stretch your bladder slowly. That's what it is. And that's what
I have
happens.
stress. I have stress, incontinence, but it added to it.
Right. Yeah, exactly. And it's hard to distinguish between like, okay, is this one stress? Is this one urge? But the stress, you should work on it. It's the knack. Every time you move, you have to squeeze. And then maybe using the clamp to push the urges.
Thank you.
You're welcome.
You shouldn't go to the bathroom too often, but I've noticed that sometimes occasionally when I'm walking and I have an urge and I try and hold it, I can't, it just leaks out before I get to a bathroom.
Right. Well, that's because the bladder is too nervous. So the contractions of the bladder are too strong. So you have to kind of work on it on 5 minutes at a time, you know, trying to push it, get the exercise to hold it, sit down and don't walk anymore. Just sit down.
I mean, most of the time I don't even feel an urge.
Right. Well, that's what I was saying. Most of the time we don't feel an urge. So it's by seeing that it's starting to leak and just stopping the leakage. Yeah.
Okay, it's 9:25. How's your time, Marie-Josée?
Okay.
Yeah, we got to be out by 10
10?
anyways, but I think, you know, I think I'll respect your time as well.
Yeah.
Are there any other questions here? Anybody have any? You got one more? Okay, go for it.
I'm actually, do you have any help for us in that area?
Well, so it's a difficult one because it's sometimes the pelvic floor muscles are not contracting at the right time. Yeah, I don't have as much suggestion for that. Yeah.
How useful is electrical stimulation?
How is
How useful is electrical stimulation from a physio? Is that something you recommend or?
That would be my last choice. I'll tell you why. Electrical stimulation helps when the person does not know how to do their exercise. It is definitely my last choice. I would do biofeedback way before electrical stim because it does not strengthen the muscle. So to me, I'd rather have the person understand their contraction and go home with that knowledge instead of doing electrical stimulation and having them go home and not knowing, because it's not like you've seen the ads on TV, Dr. Ho, that puts electrical stimulation on the abdomen, and they say you're going to have great abdominal muscles by, you know, wearing this all day. And then, well, no, they were sued, right? Because electrical stimulation does not strengthen a muscle. It gives your brain the idea of what is a contraction. But if you already are able to do a contraction, then I would work with that and not spend time doing the electrical stim. So I'm not against it at all. I mean, I teach it to physios, but there's a place for it. The place for it is when people are very weak. It's very rare that a man is weak with the pelvic floor. Women are more weak than men.
So one of the physios I went to, we did it. I mean,
okay. So, I mean, it's not bad. It's not, to me, I don't find that it brings as much value as for example, the biofeedback, so that you understand what a contraction is, that you're getting abdominals, that it's pushing, you know, the timing is not good. Practicing biofeedback is with an electrode, because the electrical stimulation is done with an electrode. So we can do biofeedback, and on the screen, when you do the contraction, you see it goes up, and then when you relax, it goes down. No, that's biofeedback. Electrical stimulation is that it's an electrical current that's given to your muscle, and it makes the muscle contract and then relax. Where the biofeedback, you do the contraction and then you see it on the screen. So then you can practice the knack. I could say, okay, you have to squeeze and cough. And then we see if you're squeezing when you're coughing, or are you squeezing way after you've coughed. So these are ways to be able to see it on the screen.
Because apparently we did biofeedback, but we called it electrical stimulation.
Oh, well, you would have felt the electrical stimulation, you feel a current. You feel,
It could be like both. of them.
well, yeah, it could be that, you know, you did a few minutes of biofeedback and then electrical stim. Yeah.
Any other questions, guys? Last question, Marie, go ahead.
Radiation therapy, is that having an effect on shrinking? prostate?
Well, that's what they're trying to do, to destroy the tissue, right? That's what radiation does. It destroys the tissue.
Clear answer where I'm going.
What do you mean?
If you have BPH.
Yeah.
And then you're having radiation because of cancer,
Yeah.
they're not necessarily tied to each other.
When I had my, I asked my oncologist about that. I said, what happens when you, what does the prostate look like when you're finished? She says, we have no idea. They don't know.
So the radiated tissue is not a regular tissue anymore. It's kind of, that's why they have a hard time to do a prostatectomy after doing radiation, right? Because it's not clear as a tissue anymore. It's kind of not, yeah, it's not good tissue. Now, BPH and cancer are two different things, right? You can have BPH, not have cancer, but with age, men have BPH. That's one of the things, and it disturbs some people more than others. So what happens is that the radiation does not get rid of the BPH, but it's trying to alter the prostate tissue by doing the radiation, and then it becomes more with scars in it. It becomes, so radiated tissue is not as healthy tissue. It's more as of a stiff tissue. It's well, it's not completely dead, but it's not a great, it's not vascularized anymore. That's what they're trying to do.
Would someone have to take or may be able to take medication specifically for BPH? Even though they have the radiation?
That I don't know.
The void and all they're doing is little drops are coming up.
Yeah.
And their stomach feels like it's gonna burst.
Well, that could be from the radiation, not from the BPH. The radiation does that. That's one of the side effects, having a difficulty initiating the flow, for sure. Yeah.
Okay. All right. Okay, guys.
It should.
You'll go on. I want to thank you all, and especially thank Marie-Josée for a wonderful. Thank you. I think we can't thank you enough, really, you know, but keep coming back. We'd love to have you back always. I just wanted to wish everybody a wonderful holiday over December, a safe and happy holiday, and a happy new year as well. And I hope that we'll see you back in January. We're going to be doing a peer-to-peer support group in the 4th Thursday of January. For the new people that are here tonight, if you want to just go and see Bob.
It's just to give us an idea of who you are, and if you leave an email, we'll keep you on our list and keep you informed as to what we're doing.
Exactly. Okay. And there's no visa. We don't ask for your visa or anything like that. Okay. All righty. Have a great night, guys.
Thank you.
Yeah. Kinatex. You just right. If you look up Kinatex, Kinetex. E. No, I turned it on.
Oh, you turned it on? Okay.
Yeah, that's Kinatex.
Okay, guys, have a good evening. Thank you for joining.